The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast, where we navigate the maze of healthcare policy and economics each week. My name is Marc Ryan, and thanks to everyone for listening in. This week's episode is titled Medicare Advantage Audit and Enforcement. The message from CMS is getting clearer. We will take our usual 3 breaks to hear about the Healthcare Labyrinth book, Lilac Software's data analytics solutions, and the Healthcare Labyrinth Health News website. So let's get right into it. I've followed Medicare Advantage and Part D program audits for about 20 years now, and I have to tell you the evolution of CMS oversight has been pretty remarkable. When I first started dealing with this stuff, CMS oversight could sometimes feel inconsistent. Standards weren't always as well developed as you would imagine. Enforcement could be uneven. That has changed. CMS has built a sophisticated audit and enforcement machine. And with that sophistication comes something else. The bar keeps moving. CMS isn't simply asking whether a MA organization has the right policies sitting on a shelf somewhere. The questions increasingly are, does the organization actually do what the policy says? Does the system implement it? Does the vendor implement it? Does the delegated entity implement? Does the data prove it? And perhaps, most importantly, did the beneficiary actually get the right outcome? That is the message I take from CMS's latest Part C and Part D audit and enforcement report based on the agency's 25 audits. And I think plans need to pay very close attention because the report is really about something much bigger than audits. It's about the future of Medicare Advantage compliance. So Part 1, CMS is no longer just auditing your policies. Let's start with what I think is the biggest change. For years, compliance organizations understandably focused on policies and procedures. Do we have the right policies? Is it current? Was it approved? Did we train people on it? Can we produce the documentation? Those things still matter, but they aren't enough. CMS is increasingly looking underneath the policy. What it is finding is that many compliance failures aren't really failures to understand Medicare rules. They're operational failures. CMS specifically points to breakdowns involving enrollment and eligibility processing, system configuration and change management, benefit and cost-sharing configurations, Part D eligibility and medication rejections, prior authorizations and appeals, and data transfers between systems. Now think about what all of these things have in common. They're operational processes. They're data-driven, and they're often dependent on technology. Let me give you a few examples from the report. CMS found situations where beneficiaries had coverage inadvertently deactivated when they moved between benefit packages. In another situation, weekend eligibility file processing temporarily terminated active coverage. And in a Part D example, transition-eligible beneficiaries were denied medications because a system was using an old enrollment date rather than the beneficiary's current effective date. Inside an IT department, these might look relatively small. Maybe it's a configuration issue. Maybe it's a file processing issue. Maybe it's a data mapping issue. But to the beneficiary, it's very different. It's a prescription that doesn't get covered. It's an unexpected bill. It's a delay in treatment. It's a beneficiary being told that they aren't covered when they actually are. And that is the critical distinction here. CMS is increasingly auditing the infrastructure behind compliance, not just the compliance manual. That means compliance has become everybody's job. ITs, claims, enrollment, finance, pharmacy, utilization management, appeals, vendor management, and of course, compliance. If your compliance department is operating in isolation, I think CMS's message is pretty clear. That's not going to work anymore. And complete information also matters. That's another theme in the report that I think is particularly important. CMS found situations where decisions were made without all the relevant information being available or considered. That includes clinical documentation and enrollee-specific information, and that becomes particularly important in special needs plans. CMS found care coordination activities that didn't fully reflect the individual needs of the enrollee or incorporate all available clinical information. And here's another important point. Having the documentation doesn't necessarily mean you're compliant. You can have an individualized care plan. You can have an interdisciplinary care team. You can check every box. But if you're not actually using the available information to understand the beneficiary and address their needs, CMS may still have a problem with what you're doing. That's a pretty significant evolution. We're moving from, did you document the process, to, did the process actually work for this beneficiary? And that's a much harder standard. With that, let's take our first break. When we come back, we're going to talk about one of the biggest compliance traps in Medicare Advantage. Your vendors may be doing the work, but CMS still holds the plan accountable. Be right back.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Marc Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Marc dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage in a private delivery model. Marc is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Marc's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back to this edition of the Healthcare Labyrinth Podcast. My name is Marc Ryan, and we hope you are enjoying this episode. This week, we're covering the latest CMS Medicare Advantage and Part D Audit and Enforcement Report, and the increasingly clear message that compliance is about operational execution, not just having the right policies. And now I want to talk about something that I think has been one of the most persistent problems in Medicare Advantage: delegated entities. Part 2, your vendors are your problem. CMS has been saying this for years, but apparently we still need to say it again. Delegation does not transfer accountability. You can delegate the work. You can delegate the responsibility. Plans remain responsible for their first-tier downstream and related entities, though. And CMS found numerous examples in the audit report where delegated entities didn't administer benefits consistently with the plan's approved benefit design or other Medicare requirements. We're talking about things like inconsistent utilization management edits, untimely notices, payment problems, incorrect appeals language, and regulatory changes that weren't implemented consistently across systems and vendors. Now, here's where I think plans need to rethink their approach. There can be a huge gap between what the plan thinks its policy says and what the vendor actually does. You can have the most beautiful utilization management policy in the world. You can have it approved by compliance. You can have it reviewed by legal. You can have it sitting in your policy management system. But if your delegated entity has different edits running in production, CMS is going to care about the beneficiary outcome, not the beauty of your policy. That's the point. Stop relying on attestations from your vendors as well. I have always encouraged the plans I've worked with to have a very disciplined agenda for monthly vendor meetings for their oversight. And I mean monthly, not once a year, not just when the contract is up for renewal. Every month, ask the vendor what it is doing in every area that it is delegated for. What decisions are you actually making? Are those decisions consistent with our approved benefit packages? Are the system edits in place operating the way they're supposed to? Are notices accurate across platforms? Were regulatory changes implemented everywhere they need to be? Are the vendor's outcomes actually consistent with your policies? And don't just ask, test it. Claims, authorizations, appeals, grievances, complaints, member materials, notices, benefit configurations. Do your own auditing. And yes, do your own secret shopping, because sometimes the fastest way to determine whether a process works is to experience it the way a beneficiary does. Don't just accept the vendor's attestation or word for it that everything is fine. Find out. And that brings us to our second break. When we come back, we're going to get into the money, because so much of the serious findings in this report involves something that plans sometimes think of as an administrative issue: financial accuracy. CMS is increasingly treating financial and technology controls as beneficiary protection controls. We'll be right back.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back to this edition of the Healthcare Labyrinth Podcast. My name is Marc Ryan, and we hope you're enjoying this episode. This week, we're covering the latest CMS Medicare Advantage and Part D audit and enforcement report, and the increasingly clear message that compliance is about operational execution, not just having the right policy. Now let's talk about money. Part 3, the money matters, and CMS is watching, because the enforcement findings make something very clear. Financial controls are compliance controls. CMS identified problems involving maximum out-of-pocket accumulations, claims payment methodologies, provider payments, eligibility changes, and low-income subsidy processing. In some cases, beneficiaries continued to be charged cost sharing after reaching their MOOP limit. In Part D, retroactive LIS changes weren't consistently reprocessed. And again, you can see the common denominator here: data, systems, interfaces, operational processes, and the handoff between one organization and another. This isn't necessarily somebody deliberately violating Medicare regulations. It could be a data problem, a configuration problem, a claims problem, a vendor problem, a file problem. But CMS isn't going to tell the beneficiary, well, unfortunately, your plan's data interface didn't work correctly. The beneficiary still got the wrong outcome. And that's why the compliance department alone can't own this. Let's talk the enforcement numbers. CMS imposed 14 civil monetary penalties involving 18 violations, totaling $1.54 million. The largest concentration of CMS violations involved beneficiary cost sharing and provider payment issues, followed by MOOP protections, LIS processing, and Part D eligibility. And here's a number that jumped out at me. 89% of the violations in the 2025 CMP actions involve financial harm greater than $100. CMS also identified aggravating factors involving beneficiaries who lacked access to medically necessary medications or services. The largest individual penalties included CVS Health at about $754,000 and Centene at about $381,000, with additional penalties involving large organizations like HCSC, United Health Group, and Devoted Health. There is real money attached to these failures, but I think the bigger risk isn't even the civil monetary penalties. It's what that CMP tells CMS about the organization. If CMS finds a systemic issue that affected thousands of beneficiaries, that's a very different conversation than finding an isolated mistake. And that brings me to something I think is one of the most important lessons in the report. Find your own problems. CMS considers whether the plan's own monitoring and auditing identified a failure. Did you find it? Did you understand who was affected? Did you fix the root cause? Did you remediate the beneficiaries? Did you act promptly? CMS's discussion of compliance program effectiveness reinforces this concept. The agency piloted an approach in 2025 that integrated compliance discussions into the operational areas being reviewed. And I think plans should take this as a very strong signal. CMS wants you to find your own problems. Think about the difference. Plan number 1 discovers a systemic claims problem through its own monitoring. It identifies the affected population. It fixes the system. It corrects the claims. It reimburses beneficiaries. It determines why the problem happened, and it puts controls in place to prevent it from happening again. Plan number 2 waits for CMS to find it on program audit. Those are not the same compliance stories, and I've always believed in proactive transparency with CMS as well. Back when I was a Medicare operator, I was very transparent with my CMS account manager. In fact, at one point, she actually emailed me and said, "Mark, I trust what you are doing. I know you're accountable." I took this as her polite way of telling me that maybe I was reporting a little too much. But the point was important. Plans can become so afraid of reporting anything that they wait until they have a full-blown compliance meltdown. I don't think that's what CMS wants. In my experience, proactive disclosure, particularly when accompanied by real remediation, can be much better than CMS discovering that you knew about a problem and didn't act, or acted too late. Trying to hide the ball can create an entirely different level of suspicion, and that's even worse. And once CMS starts digging, you don't necessarily get to decide when the digging stops. With that, we've got one last break. When we come back, I'm going to talk about prior authorization, artificial intelligence, and what I think may be the biggest change coming in Medicare Advantage compliance. Because CMS is increasingly able to connect the dots between data, operations, and individual beneficiary outcomes, and much more nimbly than they could before. And that changes everything. Be right back.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back to this edition of the Healthcare Labyrinth Podcast. We're talking about the just-released 2025 Program Audit and Enforcement Report for Medicare Advantage from CMS and how compliance is changing dramatically. Let's bring this all together. Part 4, CMS is raising the stakes. There are two developments that I think are going to raise the stakes considerably. First, prior authorization requirements, and second, CMS's increasing use of data analytics and AI. Beginning in 2026, CMS is requiring plans to make Part C prior auth decisions within 72 hours for expedited and 7 calendar days for standard requests. For Part B and Part D drugs, the timeframes remain 24 hours for expedited and 72 hours for standard requests. Now think about everything involved in meeting these requirements: clinical review, prior auth and utilization management, technology, provider communications, notices, appeals, delegated entity oversight, and data transformation. That's not one department. That's an entire operational ecosystem. And CMS is telling plans that they need to be able to demonstrate that they can monitor these timeframes, identify delays, and make sure their systems, workflows, and delegated entity oversight are all aligned. This is a very different compliance challenge than simply having a prior authorization policy. CMS and AI, the game changes again. And then there's data analytics and artificial intelligence. CMS has indicated as a broad government policy that it will make much greater use of AI and invest heavily in technology. It is doing so in so many areas. That means accuracy, completeness, and integrity of data submitted to CMS becomes even more important. Now, CMS has always had enormous amounts of data. The difference is what it can do with that data and how fast. If you have sophisticated analytics and AI examining enormous data sets, you can identify patterns much faster, and that potentially changes the nature of Medicare Advantage audits. Historically, you might think about an audit as an event only every several years. CMS comes in, CMS reviews your operations, CMS identifies findings, you respond, you remediate. But what happens if CMS can increasingly monitor the data continuously and in near real time? What happens if the agency can identify patterns suggesting potential noncompliance before an auditor ever walks through your door and as often as CMS wants? What happens if the distance between an operational failure and CMS identifying that failure becomes days, weeks, and months instead of years? That's where I think we're headed. And the report makes the possibility pretty clear. CMS's use of data analytics can increasingly focus much more swiftly on actual cases of noncompliance, corrective actions, and beneficiary impact. That is a fundamental shift. So what should plans do? Let's end with what I think plans should actually take away from all this. Stop asking, do we have a policy? Start asking, does the operation actually execute on the policy? Then ask, does the vendor follow it? Can we prove it with data? Are we finding errors before beneficiaries are affected? Are we monitoring outcomes rather than simply process completion? Are delegated entities applying these things consistently as well? When something goes wrong, are we fixing the root cause or just fixing the individual case? And perhaps most importantly, have we documented what happened, what we did to protect the beneficiary, what we did to fix the underlying problem, and whether CMS should be informed? Further, plans will need to adopt the same real-time analytics and AI technology that I just mentioned CMS is doing, so plans are on top of potential operational failures, beneficiary impacts, and noncompliance. Those are the questions that I think represent the new Medicare Advantage compliance paradigm. Compliance is becoming an operational assessment. It is becoming data-driven. It is becoming continuous, and it is becoming much more focused on the actual beneficiary outcome. I think the plans that are going to do well in the next generation of Medicare Advantage oversight will be the ones that stop treating compliance as a periodic audit exercise. They'll treat it as an operational discipline. They'll continue testing their systems. They'll continuously test their vendors, and they'll ask a very simple question. If I were the beneficiary, what would happen to me? Because that's increasingly the question CMS is asking. And if the answer isn't right, having a great policy manual isn't going to save you. The time between an operational problem and enforcement action will get shorter, and I think every Medicare Advantage and Part D organization needs to prepare for that. That's it for today's episode of the Healthcare Labyrinth Podcast. Thanks for listening. If you enjoyed this episode, be sure to subscribe and share it with colleagues interested in healthcare policy, economics, and the increasingly complicated business of American healthcare. Until next time, stay curious, stay skeptical, and keep navigating the healthcare labyrinth with me. We will find our way out together. Again, I am Marc Ryan. This is the Healthcare Labyrinth Podcast. See you next week. Take care.
Thanks for joining Marc and the Healthcare Labyrinth Podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth Podcast.